Welcome everyone who's joining in our webinar today on Toward a New Moral Economy, Ethics Essentials for Essential Workers During COVID. The issue is really very pertinent. We chose to do this webinar because it applies to all kinds of organizations at all levels in our world today. We're going to be talking about Canada, of course, but it really is a general issue. While we wait for more participants to arrive, please just gather your thoughts. We'll be going into the presentation itself within a very few minutes. We still have some people who seem to be joining. I can see that we're passing the 20 participant threshold. That's very nice. And I'll wait for a thumbs up from our technical controller, Brad Labadie, one of the directors of EPAC, to tell me that we're at or very close to the anticipated number of participants. For those of you who have joined just in the last minute or two, welcome. We'll be starting very shortly when I get the signal that the anticipated number of participants have arrived or very close to that. Of course, we always have to give allowances for the fact that people get delayed for various reasons. And our technical controller is in an area that's suffering thunderstorms, and who knows what's going to happen.
Brad? Brad, I'm hearing Robert's speech twice. Is that what's supposed to be happening at this time?
Yeah, he's talking a couple different times.
Okay.
Brad, I think that we could start. It's been at the same number for a bit now. Yep. Brad, may I start the webinar? Could you give me my signal, please?
Just watch your chat there. That's where I'm talking to you.
Okay. when you send in your comments at the end, perhaps some of the participants will want to say whether they would prefer to have heard music while this was all going on, while you were waiting.
Well, I recommend you're good to go.
Okay, thank you very much. So there we go. So welcome everyone. Thank you for joining in our EPAC webinar today on a new moral economy that asks questions about essential elements of ethical elements with regard to essential workers during our pandemic. Our speaker today, I'll introduce him shortly, but first just a few preliminaries. Whoops, I mucked something up there. Your voice lines are muted. This reduces interference. The way our dialogue will go is by written questions in the question box. Send items for the discussion at any time. I'd like to point out that for those of you who prefer using French, our presentation will be in English, as are the slides. Mais vous pouvez envoyer des questions en français si vous préférez, et je vais traduire pour notre présentateur, notre conférencier, et pour les autres. Donc, use French if you wish in your questions. I'd also advise you to pay attention to privacy and to discretion. If you don't want want to be known yourself, or you don't want to have any organization mentioned, then just go ahead and write without giving names. Okay, that's always a better idea. The webinar will be recorded and put on our website. And for those of you who are not familiar with the Ethics Practitioners Association of Canada, we work to promote ethical practices in organizations of all sorts across Canada and support ethics practitioners there. And practitioners, we understand it broadly, from those who have very specific roles in ethics through to managers and staff of all sorts, and even people outside organizations who have an interest in this topic, because our vision is of a world where people in organizations are ethically aware and act ethically. We always invite people to look at our website and to become members. So now I'll introduce our presenter today. David Nitkin is the president of EthicsScan Canada. It's a full-service ethics consultancy and corporate responsibility research house. With over 30 years experience, EthicsScan has provided ethics training, ethics audits, and due diligence partnership reports for over 200 public and private sector clients. He has degrees from the University of Toronto and York University, and he organizes and teaches applied ethics at various universities in Canada and abroad. David is a prolific COVID ethics blogger, and he leads EthicsScan's online COVID knowledge base. And very pertinent for our organization, David was one of its founders, and he served as its first president. That was back in the mid-90s. So thank you very much, David, for being our presenter today. And I'm now switching over to your slideshow, and I'll advance it as you ask me to. So I'll just stop talking and invite you to. Okay, David, you can start speaking. You should be seeing your slides, your opening slide, which says weekly ethics injection, which is a rather good joke nowadays. And here's your second slide.
I'm not showing the first or the second slide.
Which slides are you seeing?
All I'm seeing is David Nitkin is the president of.
Okay, so I'll close that slideshow and now share content. Here we go. I apologize. Do you see it now?
That's where we want to be. Yep,
Okay.
that's fine. I'm seeing toward a new moral economy.
Okay. Here, just for completeness, here's how your slideshow started. And what we see is the line, your weekly ethics injection. Hopefully, people have received their actual vaccination injections and don't get those weekly, but rather pay attention to ethics issues every week. So here we go.
Thank you very much. I appreciate the opportunity.
Okay, I'll go to the next slide.
Thank you very much, Robert. I appreciate the opportunity of appearing virtually in front of an organization that has fond memories for me, because I remember being in a Toronto pub many years ago when we advanced the idea that it would be important to set up an organization of this kind, and I'm pleased to see that it has grown from step to step. So the agenda, I'm going to be talking about 5 subjects. First of all, who are essential workers? Second of all, what traditional and new challenges do they face during COVID? Third of all, what for them is moral distress and injury? Fourth, what ethical responsibility, challenges, and opportunities do employers, governments, and professional associations face? And what are the consequences of inaction? First slide, please. So, who are frontline workers? Essentially, we're talking about 3 different kinds of workers. First of all, direct healthcare providers, which would include doctors, nurses, emergency medical technicians, contact tracers. Second of all, more broadly outside of the healthcare system, we're talking about system support workers. So all those grocery clerks, warehouse workers, agricultural farm workers, border crossing staff, and many other private and public functions. And then third of all, we're talking about congregate care workers, people living and working in nursing homes or in prisons or in shelters. So that's the population that we're talking about here, frontline workers. Next slide. What challenges did these workers face? There are both traditional challenges and new challenges. The traditional ones are fairly well known. They include things like low wages, no workplace income loss when they're ill, or no income protection if they are possibly ill. You either report for work or you don't get paid. That includes challenges like protecting yourself and your family as well, and also exercising duty of care. And we're going to be emphasizing the moral aspects of duty of care in this presentation. It's been said that there are many professions today which are not well trained from graduate school to be able to handle pandemic problems. That's true of counselors, that's true of clergy, that's true of certain kinds of medical professionals. And so there are a large number of new challenges that are being faced in the workplace. And that includes lack of proper PPE equipment. That includes a lack of knowledge of the virus's features and future. It's unfortunate that we're asking so many detailed forecasting questions about physicians about the virus when infectious disease specialists are admitting that the virus itself is changing and it's impossible to predict with certainty how it's going to develop in the population. And then most importantly, we also have moral distress, which leads to moral injury and disability. And I will focus in particular in this presentation because it comes from a couple of blogs that we have posted on what exactly moral distress is and when does it go from distress to injury. Next slide, please. So, what is the problem? In essence, what I'm sharing with you and would suggest is that many of these essential workers are paid a minimum wage or close to a minimum wage, often in very precarious work situations. They are overworked, they are underappreciated, and they are seriously at risk, both self and family and contact circle. And the challenge I'm raising ethically is it not reasonable and right for governments and businesses to offer special recognition, benefits, and compensation for endangered frontline workers? Next slide, please. So, in one of the blogs that appears on the EthicsScan site, we identify at least 7 different agenda issues that might arise, some of which will be familiar to you, but some of which are not. So that includes pandemic danger pay, and you'll be familiar with some grocery stores and some warehouse stores offering pandemic danger pay in the first wave, but very few offering it in the second and third wave. It also includes self-isolation pay, so that if you need to self-isolate at the workplace or away from the workplace, you're paid by the employer. Third, mandated paid sick leave. This is obviously a very potent issue politically. The Ford government has said that it's going to come up with a world-class program, but everything that we've seen thus far indicates that they're piggybacking on the back of a federal program when the feds themselves say this is a provincial responsibility. Next, we have the right of recall for all laid off workers, something that's very important and championed by collective bargaining units in some workplaces. We're also talking about priority vaccination for the health compromised. It's been said that we shouldn't have been surprised at which communities were most seriously affected by COVID. We could map certain populations, immigrants, congregate settings, and we would have exactly those situations, both at home and in the workplace, that have been primary recipients of infection. The final 2 social injustice agenda issues are no fault compensation and benefits for surviving family members, and food security for the disadvantaged, making sure that those people that are already having difficulty getting access to food and medicines are now getting that kind of care. Slide, please. So, what is moral distress? Moral distress occurs when someone is compelled to engage in, fails to prevent, or witness an act that conflicts with their values and beliefs. And think about values and beliefs. This is not just workplace stress, it's workplace stress of a very particular kind. And so in context, what I'm saying here is healthcare workers typically don't experience moral distress because they're trained and prepared. They have cultural norms, they have practice norms, they have messages and behavior of peers and leaders, which means they shouldn't be surprised when you have moral stress at the workplace. And so it's accepted by the profession and by their peers that there will be some stress. But moral distress, however, is something new. It's something that a growing number of professionals are reporting. They're having difficulty coping with the magnitude of unfamiliar, unfamiliar, distressing work experiences to the extent that distress becomes injurious. So we're shifting from moral distress to moral injury. And in a previous webinar I have done with nurses, some of them have said that they recall early experiences of this kind 20 or 25 years ago that remain with them decades later. When you have a situation where you're asked at work to do something that is morally offensive and problematical for you. And that, they say, will stay with them for years, and that leads to moral injury. So let's look at the next slide and explore moral injury in a little more detail. Moral injury can be experienced by anyone, healthcare professionals, staff, but also patients, families, loved ones, and administrators. It arises from sources that include injustice, cruelty, status degradation, and profound breaches of moral expectations. For example, a nurse being told that you have to reuse a personal protective equipment gear is only supposed to be used once. For example, a family member being told at the bedside of a dying family member that they can't be there at present. Or imagine a physician that's being told you have to make a triage decision. Someone will get a ventilator and someone will not get a ventilator. So this is stress of a particular kind because it's tugging and challenging your conscience. What it's saying is, in order to perform your job, you're being required to violate your principles. And that's when we have serious long-term potential for moral injury. Professionals that we've looked at describe it as moral and psychological anguish, including bewilderment, humiliation, and resentment. And in the analysis of the literature, it looks like it's not burnout, it's adjustment disorders, it's not depression, it's not PTSD in the traditional sense, it's not quite the same as moral injury in the military, but it does definitely deal with moral distress. Next slide, please. So, what is moral injury? In the literature of professional psychologists, they use military-type language that you're involved in a fight, you're involved in a battle, you're involved in front lines, you're involved in winning the war, you're involved in circumstances that are unprecedented in known human history. So this is workplace stress of a very different caliber and type. I hope that message is getting across. Unlike PTSD, the professionals and the experts in the area say the diagnosis doesn't require a qualifying exposure to a traumatic stressor. It's highly personal. It can affect a healthcare provider, but it also can include a family member. Moral stress and distress can serve as a guide for healthcare improvement, and rapid systemic interventions to address moral distress may help prevent and mitigate the severity of impact of moral injury. But now that we've laid the groundwork, let's look at some of the other examples of workplace stress. Next slide, please. All right. What are the ethical challenges and opportunity? What are the ethical challenges and opportunities caused? First of all, it's an opportunity to demonstrate an appreciation that others, by doing their jobs, sacrifice their lives for us. Second, it addresses long-term mental and physical costs of stress, depression, and illness. Third, it's an attempt to engineer new definitions of responsible care. What are the standards, design, and operational that we want for nursing homes and for home care? And finally, it's an opportunity to define a new moral economy. Things like childcare, things like a living wage, things like sickness care for workers. In effect, it's suggested that our very relationship to government is changing. First of all, because you're seeing edicts that define what public health policy will be, which change regularly. But second of all, you're also talking about more acceptance of government providing more subsidies, more income supports, and more engagement and involvement in life. Everything from childcare places to workplace benefits and to possibly a universal living wage for everyone. Next slide, please. I want to focus for a minute on self-isolation pay. This is only found in 2 provinces thus far, Nova Scotia and Ontario, and only in some regions. So you're on the front leading edge of understanding one of these 7 issues that we're talking about. This is payment by the employer for workers that need to self-isolate at work. It applies not only to asymptomatic workers who have to isolate because of exposure to COVID, but also to workers that are scheduled and off work for COVID symptoms or sickness, but not eligible for sick pay. The impact has been suggested as we get more experience with self-isolation pay include that it appears to stop the spread of COVID virus in hospitals. It appears to address concerns about staff going to work while they're symptomatic in order to avoid missing out on pay. It's either show up at work or your family suffers with food on the table. Eases the burden on staff who were exposed to the virus. Then they can isolate and test negatively. And then finally, it enhances safe patient care. So while it is a new demand or request in terms of a moral society and economy-facing workers, self-isolation pay is a trend, a new innovation that merits attention. Next slide, please. So, what about extending pandemic pay to personal care workers? It's suggested that this could be expanded not just to people working in grocery stores, but to a much broader range of participants in the economy. That includes all frontline workers in long-term care homes. That's cleaners, laundry and dietary workers, rehab activation workers, clerical workers. It would also extend to retirement home workers, including personal support workers. It would include all frontline hospital workers, including nurses, porters, cleaners, and laundry workers, rehab workers, therapists, technicians, and technologists, clerical workers, and other patient contact. And then finally, all paramedics and other frontline EMS workers. So we're talking about pandemic pay, not just in the grocery sector, but across a large number of personal care situations. Next slide, please. So this one is an interesting one that's not well reported on in this country, but is getting quite a bit of currency in Germany and in the UK. And this is the idea of people that have studied this kind of problem in the military. They are saying that if there is a parallel to the military, let's analyze that in more detail. If you're working for the military, then you get benefits that include death benefits, absence from family benefits, and the burden of not transmitting to others. And so in the military, that includes per diem hazards, that includes death and disability benefits for survivors, the cost of funerals, recompense for loss of things and citizenship. So to the extent that labor union advocates are saying this has a parallel to
Bear with us. It looks like we lost David. We're going to get him back.
we can take this opportunity to invite questions, and I'd like to not only invite questions for David, but also questions or topics for discussion among all of our participants. We have, I don't know, 3 or 4 dozen people online, I think. And so what are the issues that you're seeing within your own organizations that you're finding perplexing? Conversely, what are the solutions that you have found within your organizations that really seem to reduce the moral distress, both on the part of employees and other stakeholders, customers and so forth, but also moral distress on the part of management of an organization that wants to feel that it is doing the right thing. So please consider the things that you'd like to discuss in the remainder of this webinar.
All right, can we continue, Robert? Next slide, please. So what I thought I would do in the last 3 slides is talk a little bit about what I might call soul repair strategies. So on the ethics scan knowledge base, we have had inputs from a number of nurses and doctors and counselors and physiotherapists. And so I'm going to share with you some 8 or 10 different notions and ideas that have come out of that dialogue. It's part of an attempt to try and develop possible and preferred futures for the healthcare system. And these are some of the ideas from different practitioners in the knowledge base. So one is a recognition by government and other stakeholders of a need for a special standard of crisis care, because pandemic care decision-making may increase the likelihood or intensity of moral injury. Second, the use of psychiatrists and psychologists who specialize in trauma and post-traumatic stress disorders. Third, a strong suggestion that there be more mindfulness and meditation programs in various workplaces, although one of the participants partly notes that you can't meditate your way into wellness. Fourth, hospitals and nursing homes put in place robust plans for supporting their workforce, including true what they call crisis teams that can respond to immediate needs and an ongoing structured psychological crisis response. Next, paid sick leave and quarantine care. And next slide, we'll continue with some of these soul repair strategies. Suicide prevention hotlines, especially for solo primary care physicians. And this is an extremely serious problem because it's underreported, but there have been a significant number of suicides and early retirements with medical disability by physicians in Ontario and in Quebec. Next, expanded employee assistance programs to anticipate increased needs. A memorandum of understanding with local organizations to accept overflow special need for ongoing critical care patients. More dialogue and networking within the system, in other words. Next, an expanded support program of not only talking, but also individuals coming together to process and deal with their experience differently. If this is a more serious moral distress problem than just a coffee side chat is probably not going to be enough. And then a commitment from hospitals and organizations to provide staffing levels that allow light schedules in the coming months, giving time to process this grief without consequent pay cuts. Next slide. So if I can summarize what it is that I've said, this is a very challenging time, unprecedented in many ways. And it's a very interesting time for ethics and values professionals to debate what solutions there might be, not only for healthcare providers, not only for personal care support workers, and not only for other workers that are essential in society, but also a recognition that we're not necessarily ready for all of these moral challenges because we're looking at a very different new moral economy and society. Let me take a moment just to explain to you, those of you that know about ethics. We have a blog site. We get access to it for free. There's over 110 different blogs that are on there on all of these topics that you can look at. And second of all, if you would like to explore some of these ideas in more detail, there is a knowledge base which is available, which has a number of workshops, briefings, and learning circles. And then finally, to keep this dialogue going from today's presentation session, for those of you that are willing to evaluate the session and its impact and its value to you, and you send in that evaluation within the next 24 hours, we will extend on behalf of Ethics again a free one-day pass to that knowledge base. So Robert, that's it. Thank you.
Thank you very much. Thanks, David. What I'm going to do now is start reading the questions that have come in. Please continue sending questions. I'll go back to the slide that pertains to the question, although this one I'm not too sure which one it pertains to. Here's the issue that's been raised. Some managers have different ideas from their employees about coming into the workplace. So this is not the issue about people working from home. This is people who have to come into the workplace. So say the manager wants to see the employee, but the employee doesn't feel safe being there and feels that he or she can work from home. How would you address that kind of situation? David, over to you. David, I don't hear you. Have you muted yourself? Oops. I think David's not available for a moment. Something's happened.
All right, I'm trying to answer, but you need to understand that I'm getting triple echoes of the dialogue, and so hearing the question perfectly is a little bit of a problem. If Brad can address it as we make progress, as I understand. I can do that if you think that will help.
Sorry, I missed the punchline. You can do what?
For David, if you check on the Q&A under new, you'll see the question that Bob is referring to.
Q&A and damn it. Just a moment, please. Sorry.
Are you able to hear me loud and clear?
I can hear you. Under mute.
I can read the question to you again if you wish.
The problem is that it's being repeated more than once, and so it's very hard to. Yes, I can hear you loud and clear.
So I'll try this question slowly.
Okay.
Some managers have different ideas from their employees about coming into the office.
All right, Brad, I'm getting echo. I'm getting. Is there some way that you can just show me what the question is without talking, and I'll try and answer it?
Yes, you should have access to the live Q&A.
So the question, I believe, is what about the dialogue that would be appropriate and moral in terms of an employee wanting to come into work or not wanting to come into work, depending upon the. My response would be that this is something that is important and needs to be addressed both in a legal framework and also in terms of a personal framework. In other words, an employee should not be expected to come into work if the situation is unhealthy. And our labor laws provincially that talk about investigating a workplace to determine if it's an unhealthy and unsafe place. The problem is that that's not nimble enough to deal with the current crisis and problem. So if I had to summarize what I'm saying, if I've heard the question correctly, it is a serious problem. It's a problem that will in some way be reflected in how good and how healthy the discussion and openness is between the employer and the employee, but it is a serious problem and one that doesn't necessarily have an easy or simple solution.
Okay, here's another question, and it relates to slide 11. There we go. You, David, you mentioned the need to come up with new definitions of responsible care, for example, standards with respect to nursing homes and home care. Would you agree that there's also a need to explore standards for what we mean by responsibility, rights, and freedom in this context? The issue is where an employee refuses to engage in the sort of protective routine that the organization thinks are responsible to make sure that to preserve the health of everyone else. So an employee whose behavior, in fact, is deemed to endanger or create risk for others.
So you have to understand that I'm getting that question 3 or 4 times, all reverberating and reacting over top of one another, and I apologize. It's extremely hard to understand because the question is now being continued. What I believe the question asked is, what about definitions of responsibility? What I can tell you is that we have been working together with the nursing professions in 2 provinces to try and come up with a new duty of care standard for nurses, because the recognition is that there are all kinds of standards problems built into the nursing home and long-term care facility environment. They're very problematic. For example, the initial response to COVID was that personal care workers were working in more than one nursing home at the same time, and that added to the level of problem. So the government then said we are creating a situation where we will not allow personal care workers in nursing homes to work in more than one home, but the caveat is that that will not apply to agency workers. And agency personal care workers were 14 out of every 15 nursing care workers. So we have identified the problem, but we didn't have an adequate solution. And my personal observation would be that the problems we identified in wave one in terms of these new definitions of responsible care in nursing homes were not addressed before we had the second wave, and they haven't been adequately addressed in the way that we're looking at nursing home management in the third wave. There are some individual exceptions. The province of Quebec has hired a number of additional workers, personal care workers, and trained them, but that's the exception rather than the reality. That would be my answer, as I understood the question with a very difficult technical background.
Thank you, David. Let me ask you and our audience whether they think that there are other dimensions of ethical issues that we are seeing now. And I hope that with all the echoes, David, that you can understand this. What occurred to me in reading about some of the reports was issues of profiteering, issues of dealing with this the crisis in terms of calculations of political gain. So I would say in both of these cases, all of society is in threat, and to engage in profiteering or political gain is something that should be assessed from an ethical viewpoint.
So I might make an observation here. There are some observers of the nursing home situation who believe that the for-profit sector is the serious and hard problem of nursing homes. In other words, private ownership. There is a much larger group of expertise and literature that argues that that's not the case, that that's oversimplified, and that indeed some private-owned nursing home chains have had better outcome success due to a number of different factors. So I think my own personal perspective is I'm sympathetic about having not-for-profit care facilities, but the actual data that seems to be available both in the United States and Canada suggests that there are a large number of factors, including such things as where are the nursing homes located? Are the standards that there are 4 persons per room as opposed to 1? Is there an efficient means of offering drugs and other care support because you are a chain? So I guess the bottom line here is I understand the message about profiteering being a problem, but profit making is not necessarily the accepted definition of the problem in the nursing sector. The experts in this area would argue that it's more complex than that.
I was not asking about the legitimacy of private enterprise and the profit motive. I was asking about profiteering, strictly speaking. If I've managed to buy a truckload of toilet paper and all the stores in our area are right, and I start selling toilet paper at $15 a roll to my neighbors, I'm profiteering. That's the issue that I wanted to raise.
All right, and Robert, just to be clear, are you talking about profiteering and hoarding in general society rather than in nursing homes specifically?
Yes, in general, all facets of social needs, people's needs, and the economy. Yes, not about nursing homes.
All right, so we've actually had a couple of blogs and quite a bit of engagement on part of our blog readers. There is a certain segment of society which is wired to profit on other people's misery or on other people's fear of the unknown, the risk that they might run out of precious resources. There is a strain in broad society of some people looking out for number one. I think it's fair to say that it's probably the minority situation. The larger proportion of our population is responsible, is accountable, and is looking for not only its own well-being, but also recognizing and self-limiting excessive behavior. That being said, there are very prominent parts in the media which seize upon an opportunity of profit-making and profiteering and emphasize. I'm not sure that that's the characteristic of our society. The question that our listeners might ask themselves is, do you feel we are a more caring society now compared to 15 months ago? Is there demonstrations of local support for business? Is there demonstrations of charitable giving going up? Demonstrations of people leaving food baskets and other forms of care at the doors of hospital workers and nursing home workers? I think we have to go back and examine on our personal experience whether or not that is a change in society, or whether we have, in our hunkering down, become a little bit less of a caring society.
Thank you. Those are good challenges, and I'm going to bring up your last two slides about moral or soul repair, because you've just raised some strategies that could be used. So I invite our participants to read these, and then go on to I'll go to the next one, and hopefully this will raise some issues in your minds, and we'll take a few more questions. We're getting close to 1 o'clock, and we'll end our webinar a few minutes after 1 o'clock. We did start a few minutes late. So here is one slide of David's points about soul repair strategies, and here's another one. And to these, I think David just added broader types of action, which are really available to anyone: to be kind to others, to engage in charitable giving to the extent that one is able, to do things in kind rather than with cash, like leaving food, providing food to hospital workers and so forth. Very nice ideas, David. David, I'll pose a question of my own to you. There's been a lot of talk in these past, over the past year, about unconscious bias, which has arisen, of course, in connection with racism, but it comes up in other contexts as well. Have you thought about this topic and whether you see issues around unconscious bias in the treatment or reactions to and strategies around COVID? For instance, what occurred to me is that when we talk about at-risk populations, is there a capacity to think about broadly the social determinants of health versus thinking more narrowly? And I don't say that this is illegitimate, but still it's narrower, thinking in terms of what jobs people are performing. So the question about unconscious bias, what's coming to mind because of pandemic around that topic?
there have been some well-established experts in this area that have talked a lot about the social determinants of health. And what they argue is that we should not have been surprised that communities that have been hardest hit by COVID. So we should have been looking out for those people that are living on Aboriginal reserves, those people that are being cared for in nursing homes, those people that are living in underserviced areas without access to food security, without access to the internet. And so the question is, our society seems to have something of a moral bias, which is the term, in terms of expecting that people will look after themselves and their well-being, when in point of fact, if you're poor, if you're Aboriginal, if you're a racialized minority, there's a much greater proportion and possibility of the fact that you're going to be harder hit by COVID. And there's a stigmata attached to those people of Asian heritage, because this has been called by some people a Chinese virus. And so we have a serious lens that's been opened in terms of judgmental calls on our fellows that we should be in a better position than at. And I don't think there's enough empathy or enough appreciation of the difficulties that stay-at-home orders have on different populations. If you're white and you're able to work at home and you can go in the backyard for recreation, you're relatively well off. But if you're racialized, if you're poor, if you're living in a congregate setting in an apartment complex, it's much harder for you to be able to stay risk-free. So there are a number of experts that are being listened to with more emphasis on the part of some governments on the question of looking at and trying to finally address the social determinants of health.
Thank you very much, David. I'm going to end this this slideshow and come back with one more slide here. Whoops. Yeah, here we go. So this is the end of our webinar, and as David mentioned briefly earlier, you will receive an evaluation form by email designed by EthicsScan, and please fill it out promptly. If you respond within 24 hours, David will provide a complimentary gift, and he outlined those before. Oh, no, I don't have them right in front of me here. Oh, yes, I do. Just a second. A free one-day pass for attending and evaluating the day's session. I think there's also another option there, access to the knowledge base for 1 week, I believe. Any case, please do fill out the evaluation form. This is the first time that we've done this form of partnership with another organization that has its own objectives, which are consistent with those of EPAC. So everyone will receive that request by email. Also, I would emphasize that that it's time to become a member or renew your membership, especially, and that would then, of course, be even better. So thank you. You can also send comments about this webinar and make suggestions for the future to EPAC. Go to our website or just use that email address. Again, thank you very, very much, David. We had a little bit of technical difficulty with the sound for you. I appreciate you bearing with it, and I hope that this was as valuable for everyone else as I personally found it. So over and out from from at the Ethics Practitioners Association of Canada. And Brad, can you please end the webinar?